No one is fooled. We know exactly what's going on.
Yeah.
All righty. Well, we've got about a minute to go, so I think I'll go ahead and just launch into introductions now as folks are still hopping on the call. And I'll go ahead and stop the screen share as well. So that we can really get started here with our conversation. So once again, my name is Kristine Brown. I'm the Director of Member Engagement for the Reno+Sparks Chamber. And it's my pleasure to be with all of you today as we are starting this new series with Chamber EDU called New Year, New EDU. And the ethos of this series is to check in with some folks who hold sway in various sectors of interest in the community, people who are lawmakers, people who are decision makers, people who have a vantage point that is particularly important right now, especially in the current state of affairs we find ourselves in. And so this is actually the 5th time we've gotten to host Dr. Thomas Schwenk with us. He's the Dean of the University of Nevada, Reno School of Medicine. And we're so pleased that he keeps coming back again and again and again. He keeps answering my emails, which I'm grateful for, in order to provide our members with a very insightful look at COVID-19 in the community. And we really appreciate Dr. Schwenk's perspective because he's able to speak to testing capacity, caseload. He's got his eyes on all sorts of different aspects of fighting this virus. And so we really appreciate his perspective. And Dean, thank you so much for being with us again.
Thanks, Christine. Happy to be back. I didn't realize it was the 5th time.
I know, I didn't either, and I keep a count on all of the documents where I hold our questions, and so it was in fact the 5th one, but we haven't seen you since October. And so if it's okay with you, in effort to maximize the time, we're just going to jump right in.
Sure.
So a lot has changed since October. And really right after our call with you is when we really started to see that November spike come into play. And of course, in December, we got the good news of the vaccine too being approved by the FDA so far. So there's a lot to catch up on. So in order to start, we'll just get the lay of the land right now. So one of the latest insights that we've heard is from Nevada health officials is that we were to expect a spike in cases right around this time that were thought to be the result of the New Year's holiday, people gathering for New Year's Eve, et cetera. Would you say that we are seeing that spike currently playing out at the moment? And is it following the trajectory that we expected?
I think so. I think if you look at national data and as well as various local data sets, you can track fairly clearly changes in behavior during holidays or at various points in the fall and over the holidays, and see the little spikes that come after that. But what many public health people are talking about now is how those spikes are kind of blending into other behavior changes. And so you're starting to see a kind of a plateau, but a plateau at a pretty high level. I mean, if you follow the news, you've heard some reports from hospitals and various communities that are seeing 2 and 3 times the cases that they were seeing last summer when they thought they were busy. And now they're really much busier, and it's kind of settled in. Every once in a while, you see a little sag and you think, oh, well, maybe there's something good happening. My sense is, though, that there are sort of secular changes in behavior, meaning more long-term trends that don't necessarily follow the holidays anymore, but are starting to settle into a certain kind of steady state of cases. And now, of course, you've got the variant that's popped up in 20 plus states around the country, not Nevada yet, but it's just a matter of time. And that's because it's more infectious, not necessarily more serious, but more infectious. You're probably going to continue to see that high plateau just kind of persist for a bit.
That's really interesting. And I'm glad you brought up the variant because that's another development that is fairly new and has happened since we last spoke with you. Shifting to testing capacity, I know this is something that has been a topic of conversation since we began. Are we testing enough? Are we hitting the benchmarks we want to hit in order to get a real sense of caseload? Can you speak to our current testing capacity and whether or not we're hitting the kinds of benchmarks we need to hit in order to get a true sense of the virus's prevalence in the community?
Yeah, I think we've settled into a fairly reasonable steady state capacity, I actually checked in with Dr. Mark Pandori, the director of the State Public Health Lab, and last week, and kind of popped in and had a little chat with him and talked to some of the folks in the lab. And he was actually feeling a bit better, a bit less stressed. The staff is doing a bit better, although they're still just cranky 24/7 and are working extraordinarily hard, and we're trying to support them in several ways. But they have new equipment. They got some new equipment through the federal stimulus funds, and they've gotten some student volunteers and some other volunteers, as well as some staff capacity increase. And so they've settled into a pretty reasonable level of testing. Plus, Southern Nevada has increased its capacity as well. The public health lab is responsible for all of Nevada, but there are some specific capabilities in the South. And so all in all, I think the testing capacity is reasonable. And of course, a lot of the attention has turned away from testing to the vaccine, which we'll talk about in a bit. But I think the notable issue, though, as you all know, is that the positivity rate is still very high. It's kind of sagged a little, it was sort of over 20 for quite some time. Now it's kind of down into the 17, 18 range, but that's unbelievably high. Part of that may be because we're just testing on a more concentrated case-specific basis. We're really focusing the testing on people who are sick or who are exposed, as opposed to the widespread testing. We sort of, this doesn't sound quite right, but we sort of gave up on the widespread testing because the contact tracing is essentially impossible. We don't have the resources. The state doesn't have the resources. The federal government did not provide resources. So to do widespread community-based testing, if you don't have contact tracing capabilities, doesn't really help all that much. And if the turnaround, as it was for quite some time, the turnaround time was very long, contact tracing is worthless, because by the time you get the results back, everyone's been exposed. So anyway, my point is that I think testing's fine.
All things considered, yes,
Right.
I think I would agree with that. And to your point on contact tracing, I mean, I hear all the time about folks who are hesitant to answer the call, to even submit themselves to the process of contact tracing, or people who have a hard time remembering all of the places they've been and people they've seen in a 2-week period. So it is a daunting task. So, at the very least, it's good that we at least are hitting a testing capacity that's giving us enough of a picture to continue to move forward and to isolate cases as best we can. So you brought up test positivity rate, and I want to talk about that benchmark a little bit more, as well as hospitalization rate. We know that those two data points in particular are ones that we watch fairly closely, or have watched closely, when it comes to establishing COVID-19 restrictions in the area. So what would you say in terms of trends you're seeing with both of these benchmarks? And is there anything else that we should be watching? I know that death rate, for instance, is one that is starting to come up as a greater point of conversation, which, correct me if I'm wrong, hasn't really been a huge part of the conversation until recently. So tell us a little bit about these benchmarks.
Yeah, the testing numbers, the positivity rates, all of those are interesting, but what you really want to know is who's getting sick and how many people are getting sick. What we've seen as time has gone along is that the population that is getting sick is probably a little bit younger and a little bit healthier. So there may be a larger number of cases and a larger positivity rate, but the number of people who are getting hospitalized may be a little bit less, and the death rate might be a little bit less. So the case fatality rate has probably dropped a little bit. It was running, early on with high risk vulnerable populations and older populations. We were running 2 or 3%, which is an incredibly high death rate, case fatality rate. Now it's probably subsided to 1.5. It might be subsiding down towards 1.25. It's definitely lower because the people getting infected are younger and in general a bit healthier, but they're still in the hospital. They're still sick. And of course, one of the things that doesn't get much attention, which worries me a lot and that I follow very closely, is all of the post-COVID symptoms that people carry, and what are called the long haulers, the people who have long-term symptoms. Some studies suggest that up to a third of those who are infected will have at least one persistent symptom 6 months later. And that's really scary. If the symptom is a daily headache or fatigue or sleep disturbance or mood disturbance or cognitive dysfunction, or of course the loss of taste or smell, and those are all very debilitating symptoms and can cause some significant work and home dysfunction. Even if you have made it through the hospital and come out alive, there's still a lot of leftovers there.
No, you're absolutely right. And I don't think we can underscore enough the fact that we are living scientific discovery in real time. We are discovering this virus and what it is and what it does in real time. And you're right, we need to keep those long-term effects in view. And that will be just as important, if not more important, than some of these other benchmarks we're monitoring right now.
Yeah, it's possible that the death rate has gone down a bit, but you may have a higher number of people with long-term symptoms. And so maybe the younger, healthier population doesn't die as frequently, but there may be a larger population of people who are carrying these symptoms for many months. So it's a big concern anyway.
Agreed. And we haven't even scratched the surface when it comes to mental health triage, not just for first line responders and for those who have, really, really been at the front lines of the crisis and its effects. But also if you are chronically ill, there is a mental health component to that as well. So
Right.
we're going to be living with COVID for forever in some way, shape, or form. So the topic that everyone is probably wanting to talk about and wanting to hear about is the vaccine. And, we haven't gotten a chance to speak to you since the Moderna vaccine was approved. The Pfizer vaccine was approved by the FDA and started rolling out. Tell us from your perspective, what you know about these vaccines that are currently being used and what you know about vaccines that are currently in development.
Sure. Moderna and Pfizer, as you know, are both novel vaccines. The technology, just from a purely scientific perspective, technology is astonishing to use the virus's actual RNA, the actual genome inside the virus as the target for the vaccine is really novel. It's been under development for 10 or 15 years. There have been people who've been working on this since the first SARS in 2005. And kind of been working in obscurity until suddenly SARS-2 shows up and people said, wonder who knows about this virus and wonder who knows how we might make a vaccine. And there are people who've been working for all this time. So, the notion that this vaccine just popped up in 6 months and was kind of this warp speed project doesn't really give credit to the people who've been working on this for a long, long time. The vaccine uses the virus's RNA and causes that RNA to be taken up by a white blood cell in your body. And then that white blood cell will make the protein, the spike protein that everybody talks about, those spiky things you see on the pictures. And that then creates the immune response. So you get the immune response to the protein without having the actual virus there. That's the point of the vaccine. So the virus is not infective, the vaccine's not infective, but what it does is to create the protein to which your body reacts, and that's what makes the antibodies as well as some of the cellular immunity. So it's very novel, very exciting. And Moderna and Pfizer work roughly the same way. I don't think we have data on any sort of crossover. So we're still telling people you have to get the same vaccine twice. You can't cross over from one to the other, but they do tend to work fairly similarly. Moderna has a huge advantage, obviously, because it has a longer shelf life, 30 days as opposed to 5 days, and it can be kept in a normal freezer as opposed to the -80 freezers. And so there's been some distribution issues with Pfizer in rural areas, for example, that just don't have that capability. But back to the main issue. The main issue is that the distribution systems that we have now are kind of clunky, and there's lots of upset. And I'm sure everybody on this call has all kinds of stories of trying to get the vaccine, or friends or older family members or family members with risk factors or other people trying to get the vaccine and having difficulty. And that's because of supply. I actually think the distribution system in Northern Nevada is reasonably smooth. So I think the hospitals and some of the clinics and the health district are actually better than most. When you read about some of the chaos in other parts of the country, I think we're actually doing well, but we still don't have the supply. And so you get a little call that says such and such a group is now eligible for the vaccine, and you pop on your phone 20 minutes later and the appointments are all gone. And it just is very frustrating, and and making people crazy. So we still have supply issues. It takes time to make the vaccine, takes amazing production facilities to make the vaccine. There are transport issues, obviously. So for those reasons, everyone's kind of looking ahead to the Johnson & Johnson vaccine, which is the next one up. This is a whole different kind of technology. It actually has the protein kind of embedded in a killed adenovirus, kind of a benign virus that we all have. And so this virus then it becomes the vehicle that kind of takes the protein into your body, and then your body reacts to that protein, again, without the actual virus being present. So you're developing antibodies and cellular immunity to the protein, but the virus itself is not there. So they're very safe. They're not really anything like other vaccines. So other vaccines are sometimes are what are called attenuated, meaning that it's the actual virus, but it's been modified a bit so it's not so dangerous, or the virus could actually be killed, so it's not dangerous, and you get an immune response to that. This is actually completely different technology in which you actually take pieces of the virus, the protein that's the most important part of the virus, but not the virus itself. And that's what is used for the vaccine. So it's very safe. You're getting the usual kinds of side effects. Some people are reacting probably not to the vaccine itself, but to the various chemicals that are used in the production. So polyethylene glycol, for example, which is a compound that's in Miralax, as an example, that's used in at least one of the vaccines, and some people will respond to that. There are other compounds that people respond to. So you're getting some of the fever and the headache and the muscle ache and some of the things that you've heard about. It appears that that's more likely with the second vaccine. There's some suggestion that certain groups are more likely to have those reactions, but there's no real predictable factor that says that a group should not, that some particular person would have a factor that says you absolutely should not have this vaccine. There may be some immunocompromised issues and some other immune disease issues that would cause you to have a chat with your doctor, but in general, there are no true contraindications that we're coming across yet. You did hear the news report about a number of the Moderna vaccine in California that seemed to have a little cluster of allergic reactions, but that seems to be kind of a one-off. California said, oh, don't use that lot number. Some of that lot number is actually in Nevada, but the CDC and Nevada and other experts are saying that's really not a reason not to use it. So personally, if I get called and I know that's the lot number that I'm going to get, I'm getting it. So I'm not anxious about that.
Right, indeed. And my dad is one of those, he's an employee at Renown, and he's one of those fortunate enough to have already received both of his Pfizer vaccines, and no reaction whatsoever. Not even really a sore arm, which is pretty amazing. So hopefully we'll continue to hear good reports of folks being able to receive the vaccine with little to no reaction, and we'll keep marching along. Really quickly, before we get into the next question, which I think is incredibly important, I just want to remind everyone on the call that you are welcome and invited to ask whatever questions you have in chat. So please, as we're talking, as your questions come to mind, please don't be shy. Put those into the chat. You can either send them to everyone or just to me if you're more comfortable, completely up to you. And we will get to those at the end of the call.
Mhm.
So we know that there is a lot of misinformation and disinformation being circulated, whether on social media or otherwise, in regard to the vaccine. What are some of the rumors that you have found most concerning, and which ones would you like to address here today?
Yeah, that's an interesting question. I still kind of focus a lot on some of the basic public health issues. I'm still concerned about the lack of mask adherence. I'm concerned about the lack of distancing, concerned about families who are getting together and they say, well, we're safe because we're all family members. And of course, that confers no protection. So we see some, clusters of infections that break out from that. That now extends to the notion that once you get the vaccine, you can kind of rip your mask off and you have a get out of jail free card, and that's just not true, and it's just not something that people should be believing. We do not know for sure that when you have the vaccine, even though you yourself may be protected, it's possible that you may still transmit the virus. You could have a low level of transmission that could persist. There are vaccines that protect more against the individual getting sick and do not protect so much against the transmission of disease. So that's a concern. There's always kind of the anti-vaccine beliefs that are sort of more generic. They extend across many different vaccines that, this disturbs your immune system, which it does in a positive way. But people think that, it might cause harm. There are concerns that the virus itself will cause the disease. That absolutely is not true, especially with the way these vaccines are formulated, as I mentioned. I think we're all concerned about that general approach. There are some people, of course, and you've heard about this, who got exposed to the virus just about the time they got the vaccine, and several days later they got sick because the immunity had not ramped up fast enough, and they were already in the early stages of the illness. They just didn't know it, and that always causes people to think, "See, the vaccine made me sick," and so we want to counter that belief. The immune response starts to ramp up in a week, gets better at 2 weeks, gets better at 3 weeks. Then you get your next dose and you get a huge bump after that. But there is a period of time after the vaccine when you're still vulnerable. So we're a little bit concerned about that. But I guess in general, I'm more focused still on the public health issues. I guess I'll just put it that way. This is still a public health issue and still requires masking and still requires distancing. I guess I will say that a lot of the concern about the economy would really be helped if we were all more compliant. If everyone was compliant with some of the public health measures, then we might all be more comfortable going shopping, going to the store, being out and spending money. I'll just say personally that when I see stories of people without masks being let into stores, it's just one more reason why I'm not going out. And so if people want me back in the store spending money, I think we need to have a lot of compliance around some of the public health measures. I see a question from Melissa about vaccines protecting against the second strain. Yes, as best we know, the variant still is covered by the vaccine. So I think we're good.
All right. That was a nice, easy answer there. No, I've heard the same thing, which is, of course, a huge relief as we're hearing more and more about this highly infectious variant. So at the current rate at which Nevadans are being vaccinated, when would you anticipate we're ready to move into the next level of these new lanes of vaccination that were recently established at the beginning of the month?
Yeah, I wish I knew. As I said, it's all about production, and the production and the distribution from the factories is somewhat unpredictable, somewhat spotty. None of the states are getting what they thought they were going to get. They allocate vaccines as best they can. I think that the production will pick up. You'll get a third vaccine coming online probably in early March, the Johnson & Johnson vaccine, which seems equally effective to the first two. And so that will help. And my guess is that, you're starting to see now the 70 plus lane opening up, and I would guess maybe 65 plus might pop up in 2 or 3 weeks, and then you might start to work through other populations. But as I said, it's very unpredictable, and it's all about production, and
Right.
it's real hard to say. You do see some variability. Different states are opening up different lanes, so it makes people anxious because they see a state that seems to be doing, let's say, 65 and up, and Nevada just now moved from 75 and up to 70 and up, and that seems unfair in some way, and it's all about state rules and state regulations. I'm looking at the question from Karen, age groups and frontline workers getting priority. Haven't heard about people with underlying health issues. This is a really important question, Karen, and I appreciate you asking. We those of us who have some responsibility for managing these vaccine programs are very anxious and uncertain about how to manage that issue. We do not have data that really will put in rank order the risk factors. So you have certain known risk factors: diabetes, obesity, age are 3 of the most important. Other immune diseases may fall in there, but we don't have a good way of quantifying that. So if I am forced to make a decision that says, well, I think this group should get the vaccine before this group, I do not have a good quantitative basis for making that call. And so the state public health people are doing the best they can at kind of working down in age groups, and then probably getting into some chronic health conditions for younger age groups. The reality is that many of these risk factors actually do predominate in older age groups. And so you kind of get both that way when you get older patients. But it's still a troubling question. And to make an ethical decision that says this obese 40-year-old should get the vaccine before this healthy 70-year-old, that's really a tough call. And so public health people are doing the best they can. Also, just draw your attention to Julie Ardito's posting in the chat box about the study that some of our investigators at UNR just finished that does look at vaccine adherence, vaccine compliance, vaccine interests. And Nevada's similar to other parts of the country. About 2/3 of the state says they're interested in getting the vaccine.
All right, so we're approaching the end of the call, but we still have some great questions in chat and also a couple other questions to address. Dr. Schwenk, are you okay to hang on for about 5 extra minutes so that we can
Sure.
go through some of these? Okay, thank you very much. And of course, if anyone needs to hop off the call, that's 100% okay. You can always submit a question and then leave. And these sessions will always be available to watch on demand after the fact on YouTube. So just visit the Reno+Sparks Chamber of Commerce channel on YouTube, and you'll be able to watch any of these Chamber EDU sessions on demand whenever it's convenient for you. So we are not here to make a ton of predictions, but these next couple of questions may fall a bit into that category. And so, I don't want you to say anything that that you would not want to put a stamp to, certainly. But because of your perspective, because of your insight, we would just be curious to know what you would think. So, knowing what we know about, statistically speaking, vaccine sentiment or sentiment around getting the vaccine, what percentage of Nevadans would you anticipate will get the vaccine as it becomes available to them? And do you think that percentage of people will be enough to reach the quote unquote herd immunity threshold that we've heard so much about?
Yeah, I think it's on the borderline. As we mentioned, we conducted this study of kind of a convenience sample. It was just a couple thousand people who responded to sort of a widespread survey. And as I said, about 2/3 of Nevadans are interested in the vaccine. There probably is a bit of a learning curve. And so some people will say that they're not going to get the vaccine now, but what they're doing is actually tracking the vaccine. They talk to their friends, they see what kind of side effects, they see if anything new pops up that's worrisome. And so you might start to creep up above that over the next several months. So maybe by April or May or June, you might get a little higher response rate maybe will creep up to 70, 75, 80%. That is kind of on the borderline for herd immunity. Early on, when this started being discussed, you heard some of the public health people say, well, we need at least 60%, maybe 70%. Now you're hearing a little higher numbers, people saying, nah, we really should creep up to 70% or 80% immune to try to shut down transmission, as well as open up the economy and open up social activities. And so I think we're kind of on the edge. I mean, that means that really everybody who says that they're interested in the vaccine gets the vaccine, and nearly everybody who gets the vaccine has a high level of immunity. And those are both asking a lot. So I think we're going to have to keep creeping up. And if it turns out that, we have to get a booster, maybe it may be, as they do more studies and you see how long immunity lasts, that maybe we're going to get boosters every fall like we do for influenza. The latest data from Moderna now is out about 6 months or 7 months, and so far the immunity seems to be holding. So that's a good sign. So maybe we won't need to do that. But anyway, my point is, I think this is not a, suddenly everybody is immunized and we throw off our masks and we all run out into the streets joyful. It's not going to be like that. It's going to be a slow, gradual improvement.
Right. We know the vaccine is just one piece in getting a handle on COVID-19, just one piece of the puzzle. And to your point, sentiment around mask wearing and social distancing is just as important, if not more important, especially right now when it comes to tackling the virus.
Right.
So in thinking about those three things in concert, so vaccine, the vaccine becoming more readily available via production, via transportation, and more people actually receiving the vaccine, working in concert with mask wearing now, working in concert with social distancing guidelines and even other restrictions that are in place now. When do you foresee Nevada's restrictions beginning to lift in any sort of way?
Yeah, pretty tough to say.
Mm-hmm.
I think if there was a real high level of adherence to the public health measures, to the masks and distancing, you would start to see a real drop off in the positive rate, a real drop off in hospitalizations, and people will start to feel more comfortable. And so maybe you'd see some loosening by, I don't know, April or May. Some of the national public health experts, of course, are saying, no, it's more summer, late summer before things really get better. But then, of course, you're coming into the summer and it's a little safer to be outdoors, maybe dining outdoors, shopping outdoors. So maybe that will help a little bit as well. But it's not in the next month, I don't think, or the next 2 months, maybe not the next 3 months. I will take this opportunity as well to say it's not just about the economy or schools or other issues. It's also the burdens on the healthcare system. Our healthcare workers, the frontline people, and we have some of those, and of course, many of the hospitals and facilities in Northern Nevada all have all their frontline folks. They are really getting stretched and really getting burned out, and it's really hammering healthcare workers, especially. I'm particularly sensitive to nurses as real frontline at the bedside, watching people die and watching them say goodbye to their family members on their iPad. And it's taken a toll. And so if no other reason, we should be more attentive to our public health measures just to protect our friends and family members who are all doing this work as frontline healthcare workers.
There's so many ways that it's important for all of us in the general public to connect to the reality of COVID-19. And it's not just having the virus ourselves or knowing a family member who has the virus or struggling through some of the effects of the restrictions. But it to your point, it's very important that we connect to the experience and have empathy for the experiences that our healthcare workers are having, which are just unrelenting. unrelenting effects day in and day out, and the mental health toll alone of being at someone's bedside, perhaps multiple times a day, witnessing deaths that are happening, and kind of in a vacuum. These are things that we need to keep at the forefront of our mind. So thank you for so much for bringing that to our attention. One quick question from the callers before we close out with some information about what you and what your team are doing at the UNR School of Medicine in regard to COVID-19. So this caller is wondering, is it true that once there is a positive test that an individual will continue to test positive for up to 8 weeks or so? And if that's the case, is this inflating the numbers?
It's possible that it's inflating a little bit. What you're getting at in this question, which is an excellent question, is whether a positive test always means someone is infective. And the answer is no, that some of the virus's genome hangs around for a while. And so it is detected by PCR testing, which is what PCR does. And so it will detect some of these fragments of RNA that are floating around and could show as positive, even though that person's not able to transmit the virus anymore. But that's not generally when people are getting tested. I mean, yes, if you kept testing someone, you'd keep getting lots of positive tests for weeks after, but that's not mostly the tests that are being done. Most tests are being done because someone was exposed, someone's ill, and so it's being done more upfront at a time when that person could well be infective. And once someone gets sick, there's not much testing that's done after that. I mean, every once in a while there is, and if someone thinks they truly got reinfected, which does happen very rarely, they might get retested. So yes, technically you're correct. It's possible some of the positive tests are in people who are not infected, but mostly not.
All right, thank you. So we are now at the end of the call, and so we'd like to finish with some good news, with with a hopeful look at the future. So Dr. Schwenk, please share with us what the UNR School of Medicine is doing right now in regard to COVID-19. I know that you and your whole team have been incredibly active, when it comes to, actually offering your students to be on the front lines of the healthcare crisis, as well as research. So tell us what you have on tap.
I'll do that, but I'll answer Chad's question very briefly. Most of the population studies so far show that about 10% or so of the population has been infected in a way that they've developed immunity. So that's a start on herd immunity, but obviously not even close to enough. Interestingly, some studies show that the general population might be upwards of maybe 12%, 13%, 15%, and healthcare workers are actually positive at a lower rate. So being on the front lines in proper PPE actually protects you to some extent compared to the general population. But anyway, those are the numbers. So what are we doing? We have some research going on that looks at some of the GI effects of the virus. So we've got some GI experts who are looking at how the virus will affect gastrointestinal function. We've got some people who are doing some work on some even more advanced testing capabilities, some point of care testing, meaning right at the point of delivering medical care, you could do a test right on site that's more accurate than the current point of care tests. So we have some of that work going on. We've gotten almost all of our medical students vaccinated so that they can be out again. They're workers. I mean, they are students, but they're also contributing in many ways. They're contributing to some of the vaccine programs themselves. They're volunteering for some of those programs and volunteering in some other ways, as well as their clinical education. So we've gotten them mostly immunized. Our residents are almost all immunized. They're on the front lines in the hospital. We're managing the vaccine program for our healthcare workers. So all of our staff who are in the clinics, in the waiting area, the medical assistants, the nurses, the receptionists, and others are vaccinated. So that's a positive feature. We're now trying to manage the program for some of the in-person UNR faculty and staff members. So there's kind of a high risk group that really has to be in person, has to be on campus. sometimes for teaching purposes, but also facility staff and IT staff and others who really are the people who kind of keep the university running. They're higher risk, so they're getting vaccinated as the supplies are available. So we're trying to hang on in any case, and trying to do the best we can.
Absolutely. And you know, I speak not only for us here at the chamber, but also for all of our members and partners when I say thank you. You know, you hear it from us a lot. We need to cover up for commerce, but I think we also need to cover up for community. We need to cover up for compassion. Now is the time to recommit to wearing masks in public, and where applicable, to adhering to social distancing guidelines. Now is the time to cover up for commerce, compassion, and community, and especially for the sake of our healthcare workers, of which you are one. So thank you, Dr. Schwenk. We appreciate you. We will probably be having you back sooner than later, because we certainly, you know, filled a ton of time today with a ton of excellent questions, but it's evidence that we should not wait so long to talk to you and wait so long in between visits. So thank you so much once again. Thank you to everyone who joined us today. And of course, visit our website, check out what other Chamber EDU courses are being offered in the coming weeks. And also visit our YouTube page if you want to watch this one again, or show it to someone else who needs the information. So thanks to everyone once again, and we will see you again soon.
Thanks, Kristine. Anytime.